So let's just get right in it. So most of this was from Murray Shames's talk last year, and I did not proofread this heavily. Murray's a little bit nutty, so if there's anything weird in here, he is to blame, not me. So there's going to be some repetition here, but I think repetition is good for something that you don't see a lot. So I'm specifically going to be talking about venous TOS or effort thrombosis. Paget-Schroeder, it has a lot of different names, but it's rare. So only about 3,000 to 6,000 cases in the U.S. per year. This one tends to happen more in males than females, and more often in the right arm, and that's simply because people tend to be right-handed. And it's really a disease process that follows repetitive activity or vigorous exercise. So how does it happen? Well, we just learned a lot about the venous outlet in that triangle there, and so repetitive movements or compression in that area can cause scarring to the vein. That can eventually lead to clot formation. Other things can cause it, like clavicle fractures and weird things, but most of the time it's just this repetitive, especially overarm, reaching up movement. Swimmers particularly get it a lot. But it can happen, a lot of athletes. We've seen it in hockey players, football players. So it just can be anybody who has repetitive arm movements. They used to think that there was some component of hypercoagulability, but then a lot of series showed no, it's probably not true. Now there's one modern series that says that they have a higher than normal rate of hypercoagulability, so it's just something to keep in the back of your mind. And we learned all about this in the last lecture very well, so I'm not going to belabor that point. So they come to you like you would expect somebody to come with a big swollen arm. Usually they have this history of kind of repetitive motion or movement that brought it on. It doesn't have to be complete. It can be intermittent. It can be something that they notice or positional, anywhere to extreme swelling. But almost all of them will report some kind of repetitive or vigorous activity. So here's a big swollen arm. So when you do the venogram, and we'll get to that, you have to look for these collaterals. And how does the subclavian vein collateralize to the SVC? It usually goes through the jugular vein. So you see a lot of these, people call it the first rib bypass, or a lot of collateral veins coming across the first rib. And it usually drains into the jugular. I think my wife was supposed to talk to you about the azygos and hemiazygos system this morning, but she was on about 3 hours sleep, so I'm not sure how coherent that was. I'm sure to you, the lecture this morning seems about 10 years ago. So we'll just leave it at that. So venous disease has evolved a lot. I remember my fellowship, like it was, second-class citizen. We were here to save arteries and treat strokes and aortas, and it was relegated. Somebody did the venous work, but I, as a fellow, even never worked with that person. And we used to send out a lot of people with TOS or treat them either incompletely or not even properly identify it. It reminds me a lot of May Thurner. People would have swollen left leg. We do a ultrasound, no DVT. Here's some compression stockings, go home, and never treat the underlying problem. So our evolution of this is important, and I think you guys are learning at a time where hopefully almost all your training programs, you'll have somebody who does a fair amount of TOS. So you have to recognize that it's treatable, extremely treatable, and you have to realize that the quicker you treat it, the better off they'll do. So they say 14 days. That's from a classic study from UCLA, published about 25 years ago. But the quicker you lyse that clot, the more complete resolution, better it'll be. The mistake you don't want to make is somebody comes in with a swollen arm, you do an ultrasound, there's axillary vein clot. You're like, oh, you have an upper extremity DVT. Put them on Coumadin, follow up in 3 months, because you've done that person a great disservice. So you have to think about it to diagnose it. So ultrasound, the problem with ultrasound is sometimes they get very big collaterals, and depending upon your skill of your ultrasound tech, they may not know that that's not the subclavian vein, despite it being in the wrong location. So we've seen some errors in specificity and sensitivity. But like I said, you have to think about it. Some people do CTV, MRV, but in our practice, if we're thinking about it, the next step is usually to get a venogram. Because you can miss it in a lot of other studies and waste time as well. So if you're going to require the venogram for treatment, if there's any possibility the patient has it, usually we have a low threshold. It's fairly easy to do. If for some reason the arm is very swollen, use ultrasound. You don't want to access the cephalic vein is the main thing, because if you do, you can bypass some of the clot and your catheter won't be in the right position. So you want to make sure you get into the basilic system somehow so it goes in the proper location, gets in the axillary vein. And even a venogram can have troubles with diagnostic sensitivity. So here's a venogram of somebody with TOS, and you don't know it until you elevate their arm and see the compression. So a high index of suspicion will help you diagnose it as well. So the first thing and the most important thing we want to do is get rid of that clot. Right? Clot's not just dangerous in and of itself. The longer the clot is in contact with the vein wall, the more damage it does, and that damage can often be permanent. So just like lower extremity DVT, the quicker we diagnose it and the quicker we get rid of it, the better the patient does. And then you want to get rid of the source. And this used to be a controversial topic, whether to take out the first rib or not take out. It's pretty much resolved now. Probably 95% of vascular surgeons would agree that first rib resection is a mainstay in the treatment of venous TOS. What you do with the vein is still a little bit unclear. Should you just lyse it? Should you do an angioplasty? Should you do an open reconstruction? The only clear thing is you definitely don't want to do a stent before you relieve the underlying compression, because the stent will just fracture. You see a lot of that, especially if you do some dialysis work, where they all come in, they have these kind of fractured subclavian axillary stents, and it's just somebody didn't recognize that their underlying problem was actually TOS and on top of their dialysis access, and they went ahead and stented it like they would in another location, and it invariably fractures, and you often lose that extremity for access. So in the old days, a lot of people just got put on Coumadin, but they had a lot of problems. 80% had some residual obstruction, and almost all of them had some kind of residual symptoms. So Coumadin alone is not the treatment for this entity. This is the landmark paper from UCLA where they first described thrombolysis in the United States. And they saw much better success than we were having with Coumadin or traditional anticoagulation. And then this is where that 14-day comes from, where they had 100% success if they got to them within 14 days of the onset of the symptoms. There's, I guess this is what the talk is supposed to be about, catheter placement and management. You put the catheter in, you drip TPA, and that's your management. But there's different ways to do it. I don't know if you have an ECOS catheter, if you do, suction thrombectomy. I don't know, or I do know, none have been proven to be superior over the others. So if you have a preference and you think that your POSIS system will work faster than conventional, go ahead and do it. Most people will drip like 1 milligram an hour for at least the first 6 to 8 hours, recheck it, and then maybe drop it. So I check fibrinogen. I was taught to do it. The science is probably a little bit hokey. But you do want to, put them in an ICU setting or somewhere that can be closely monitored. But you basically put the catheter in, and usually it takes about 24 hours. It depends on the extent of the clot. But keep bringing them back, keep repositioning the catheter. This goes with all thrombolysis. It only works under specific circumstances. One, that the catheter holes are actually in the clot itself. And the other thing is there has to be flow through it. If you just took a jar of clot and you sprayed TPA in it, it wouldn't do anything. It requires the homeostasis of the active flow of blood to work. So TPA does not work when there's no flow through it. So that's why you want the catheter all the way through the clot, because that establishes some flow around the catheter and through the clot, and the TPA will work that way. That's true of arterial TPA ever. And the safest way to use TPA is to have all the holes in the clot itself. So you want to give as little systemic TPA as you can, because that's where you get the bad side effects, like stroke and death. So most people, it looks like this. You 24 hours and it still kind of looks like garbage. But they'll do better clinically if you relieve the underlying compression. So some people don't like to leave it like this. Some people go in and angioplasty or even patch angioplasty it. But in general, they'll do better than they were before, even if it doesn't look great, as long as they have flow through it and you relieve the compression. So what do you do? It's like I said, stenting and angioplasty even are probably not the best idea before you relieve the compression, because you can damage the vein or create a bad problem. So again, this used to be debatable. We used to say, oh, some people do well without it, but now it's kind of got to the point where you're really, mistreating the patient if you don't do it. And most people would recommend doing it on the same admission. So I know we used to see Julie Freischlag talk a lot about this when it was still kind of controversial, and she would beg people, like, if you don't want to take the first rib out, just send them to me. Ship them over to me, and I'll take the first rib out. But it should be done. So we've kind of all come around on that theory, and so we do it. And then how it's compressed, you also, the anatomy is not super complex. There's a triangle there, and it doesn't have to be the anterior scalene or the costoclavicular ligament, but it's some component of that. So you want to just make sure you free up the vein itself and do an extensive venolysis to remove any of the compression once you get the first rib out. What do you do afterwards? This is still a little bit controversial. Julie Freischlag leaves it alone. Dr. Molina recommends patch angioplasty. No proven benefit to any of these treatments, so you can kind of do what you want. And again, the timing is very important. The quicker we deal with this, the better off the person will be, especially, this is usually a young person, healthy, active, so you want to try to get them back to their baseline. We used to, again, send them home on Coumadin, bring them back later, but now, generally, on the same admission, you take the first rib. So this is actually a meta-analysis done by Murray Shames's group in Tampa, and they found, I think there's 12 articles that deal with this, and they tried to lump them into people who had their first ribs resected in some kind of venous intervention, and then people who did not get their first ribs out. And when they looked at all these, they got 12 studies in, and majority of them did have some kind of first rib, but they had 168 who were not treated with rib resection. And when you look at the results, it's pretty clear that the first two groups had their ribs taken out, the last group, no rib. Greatly improved symptom resolution and patency when you take the rib out versus leaving it in. And so again, patency is improved, greater symptom relief. But when you compared everybody who had the rib resected, whether you did anything to the vein or not, then it was a little bit unclear whether any intervention in the vein is necessary or not. So that, again, kind of up to you and whoever's training you. So just more from this meta-analysis, the people who didn't have the rib resection, about 40% of them would come back and need something else additionally. So it's most people now agree. There are dissenters. Johansson says, maybe this is just based on old technique and maybe we don't have to do it. But I think that most people now agree that it's to take it out. The modern series from Stanford showed 23% who were treated with just lysis would come back and need something else done. There is no modern randomized controlled trial, though, so I'm not sure if there ever will be one because we seem to have consensus. So what do you do if it's still occluded? You've tried thrombolysis, you're going to decompress it, but you still don't have flow. You can do jugular turn down, although most of the ones reported in the literature are pretty bad patency rates. Basically, you want to base it on their symptoms. Hopefully, you get enough flow that they can be symptom-free. Sometimes they have to wear a sleeve for a little bit, but generally, you want to get them back to activity. You wouldn't do a jugular turn down or anything like that in someone who's essentially asymptomatic because it's definitely not worth doing. So again, all patients, that's the main message here, is all patients with venous TOS should have a first rib resection. The treatment is not just anticoagulation alone. That's Murray's institution. I left that in there for him. So they do, I think, a lot of transaxillary, which I do not like. It's kind of difficult to see, especially for venous TOS, but this is, kind of how they set the patient up for transaxillary. Now, transaxillary is good as far as cosmetic outcome. I think it's probably good for neurogenic. I just find the exposure to be greatly inferior, really, when you want to kind of clean up that whole triangle we talked about and get good imaging. One thing I would strongly recommend is on YouTube, Dr. John Eit has an excellent how-to video on how to do an infraclavicular exposure and first rib resection. He's a master surgeon and he's really quite adept at explaining things. And so, I think in the past in this course we were able to do that, but we got cut back on our anatomy time yesterday for some reason. So again, that's the triangle, and I thought there was one slide. Oh, and then this is kind of the exposure. And so that's the infraclavicular exposure. And so you have really great view of the vein. So if you are considering doing some kind of venous intervention like a patch angioplasty, I think infraclavicular exposure is definitely the way to go. There is another option, which I know they do a bit here for people on dialysis who maybe can't go through such extensive surgery, where you can just resect the clavicular head, and that decompresses that as well. And apparently, I don't do this particular procedure, but apparently it's obviously you wouldn't do it for an athlete or a swimmer, but for a dialysis patient, it might be kind of a less invasive option. Have you done that? Yeah. Yeah. So Marie did a few on a patient. The patients seem to do well. Again, you're not going to do it on Olympic athletes, but on dialysis patient, I think it's kind of a less invasive way to decompress that, and especially if you want to preserve a dialysis access. And then there's other things, but I think we'll end there. Thank you.